Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. This episode features content from an educational webinar titled Strategies for Optimal HIV Treatment and Prevention, Answering the Questions on PrEP Initiation, featuring Dr. Linda Gale Becker and Dr. Meredith Clement. Dr. Becker is Professor and Director of the Desmond Tutu HIV Center at University of Cape Town in Cape Town, South Africa. Dr. Clement is an assistant professor in the section of infectious diseases at Louisiana State University Health Sciences Center at University Medical Center in New Orleans, Louisiana. For the full online educational program, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Becker and Dr. Clement have to say.
Thanks so much for having me. So I will jump right in. So the first thing I do want to talk about before we even get started discussing PrEP is sexual history taking. I think this is a really critical part of your relationship with your patient or your client. One thing that I like to keep in mind is something that a mentor once said to me is that not taking a sexual history is doing a disservice to your patient. So sometimes you feel like it's not comfortable for the person in front of you, your patient, or for, you yourself as a provider. But I will say the more you practice this, the more it becomes routine and the more it becomes comfortable for both of you. So to get started, the 6 Ps or sometimes 5 Ps, but we like to throw in the plus or the pleasure as the 6th P, is just a way to kind of remember what questions to talk about with your patients. So for partners, I actually like to ask as a kind of warm up, can you tell me about your current relationships? Asking about the gender or the genders of someone's sexual partners is an important question. And these questions in some ways are designed to risk stratify your patients. Although I will say that more and more we're shifting away from this concept of risk. And I like to frame it as more addressing your patient or your client's sexual health and sexual well-being, sexual wellness. So asking them about the relationships. You also want to talk about safety. So making sure they've never been, or they're not being coerced or forced to have sexual activity against their will. I do ask about new partners just to get a sense for, routine partners versus new potential exposures. And then moving into past history of STIs. This is important in my clinic because if they've had syphilis before, it helps me direct what tests to do. But it also, again, kind of gives a sense of sexual behaviors and potential candidacy for PrEP, as we're going to talk about on the next slide. And then as far as protection from STIs, asking about what they are doing to protect themselves, condom use, whether it's sometimes, always, never, usually, did they use condoms with their last sexual encounter? Also addressing vaccinations, particularly if you're providing primary care for your patients. You want to know what vaccinations are needed to keep them protected from STIs and the complications of STIs down the road. And then in practices, this really just comes down to what types of sex they're having. And again, just making this comfortable for the person in front of you and often using language that they identify with. So if it's gay or bisexual men, and their language is to talk about their versatile top and bottom, that's the language I use. And then asking about transactional sex, I think, is an important question as well. And then for those assigned female at birth, asking about pregnancy intentions and in particular, are they interested in contraception? And then either providing that for them there or offering referrals. And then finally, the fun part really is sex pleasurable for them? Part of what I think is really important for your patients to get a sense of is that you really care about their sexual health and their sexual wellness. So I really try to emphasize that, it's important to me for you to have a happy, healthy sex life. And so making sure they're not having any difficulties with sex, if they need support regarding sexual orientation or gender identity, and then again, safety. So moving on to the PrEP guidance. So this figure actually is similar to what is produced in the CDC guidelines that were last updated in 2021. Again, I don't ask this question about sex with men, women, or both. I say, what's the gender or genders of your sexual partners? And the guidelines really, I kind of think of these as buckets for candidacy for PrEP. I want to highlight, and this is something I really, really emphasize to folks when I'm doing trainings or talking to providers about PrEP. Currently, the CDC guidelines have been updated that we should be talking to all adults and adolescents who are sexually active about PrEP. We should be initiating that conversation, normalizing that conversation. And then anyone who requests PrEP should be prescribed PrEP, regardless of what they tell you regarding their sexual practices, because sometimes people don't want to disclose certain sexual activities. But when you think about the actual kind of buckets or these categories for candidacy for PrEP, I'll just go through them briefly. Does the person have an HIV positive partner? If so, does that person have an unknown or detectable HIV viral load? And if so, that would be an indication to prescribe PrEP. Do they have one or more sex partners of unknown HIV status? And that really applies to a large majority of the patients, at least that I see. So this is really easy candidacy for PrEP. And if they're not always using condoms, that would be an indication to prescribe. One thing I just want to highlight while I'm talking about this, and this has to do with kind of taking the risk conversation away from the individual. You're asking about their sexual practices, but often if they are sexually active and you live in a high prevalence area, that's a reason to give PrEP. So I live in New Orleans. We have a very high HIV prevalence. I talk about the community risk. Anybody who's having sex in New Orleans is a candidate for PrEP, and make it about the community, not necessarily the individual. And then finally, has the person had a bacterial STI in the past 6 months? And if so, that would be another indication to prescribe PrEP. And again, I'm just going to emphasize one more time, anyone who requests PrEP should be prescribed PrEP. As far as the how-tos for doing that PrEP initiation, starting with a lab assessment, we want to see HIV testing within 7 days, creatinine clearance, check a creatinine and make sure that creatinine clearance is greater than 60 if your plan is to initiate TDF-FTC, and greater than 30 for TAF-FTC, and that's tenofovir disoproxil fumarate co-formulated with emtricitabine and tenofovir alafenamide co-formulated with emtricitabine respectively. Hepatitis B and hepatitis C serologies, bacterial STI testing. And then if you are considering TAF-FTC for your client, you would want to get a lipid panel and a weight at baseline. And then when you're taking your interview and doing your physical exam, one priority would be to make sure that that person hasn't recently acquired HIV or recently been infected. And so are they coming to you with possible acute HIV infection? And so you want to assess for signs and symptoms of acute HIV, some of which would be fever, fatigue, myalgias or arthralgias, rash, sore throat, diarrhea is actually one too, and sweats. And then you assess their vital signs. You can assess for adenopathy or any other signs on physical exam that would be concerning. You always want to ask patients about what other medications they're taking so that you can appropriately evaluate for drug-drug interactions. And then your counseling is going to be about time to protection, adherence to the medication, risk reduction support, and any other questions they have. We see a lot of concerns about side effects. So talking through, I think when clients or patients feel that you really know how to address side effects and you're knowledgeable and you can really reassure them that PrEP is not just effective, but very safe, I think it makes a big difference for the person in front of you on their decision of whether to initiate PrEP or not. And then some clinics can provide same-day PrEP if they have capacity to do rapid testing and they have access to it immediately. And then if not, then you do want to let them know the plan for, we're getting your HIV testing today. I intend to have it back in X amount of time. I'll give you a call. I'll prescribe it to your pharmacy and you can pick it up right away or return for your injections if you're going the route of injectable PrEP. And so just to summarize PrEP eligibility by regimen, I'll just kind of hit the highlights here. TDF-FTC or daily TDF-FTC is an FDA-approved guideline recommended regimen for all the populations you see here. For on-demand TDF-FTC 211, which Linda Gale is going to discuss a little bit more thoroughly, this would be considered off-label for those assigned female at birth because it has only been studied in men who have sex with men and transgender women. The same actually applies for TAF-FTC in a daily regimen, not on demand. But for TAF-FTC, it's FDA approved and guideline recommended for men who have sex with men and transgender women. And those are the populations in which it has been studied. It has not been studied in those assigned female at birth. Injectable CAB is considered FDA approved or guideline recommended for all populations. And then the depivoting ring, unfortunately, we will not have access to that in the United States, but it did receive favorable opinions in Europe, and it's available in some African countries. And so that would be another potential option for those assigned female at birth. And so now I just want to go back to 2010, the IPREX study, which was our first large clinical trial looking at the use of PrEP, once daily oral TDF efficacy in men who have sex with men and transgender women. That was followed by the Partners PrEP and TDF2 studies, and then the Bangkok tenofovir study in people who inject drugs. So these were the early large clinical trials. You can see the efficacy for reducing HIV incidence was not overwhelming, but this really had a lot to do with adherence. And then these large clinical trials have been followed up by kind of more encouraging open label extension or demonstration projects. And so I want to highlight the PROUD study, which actually showed an 86% reduction with immediate versus deferred PrEP. And then the DEMO project, which was US-based, really only 2 HIV infections occurred out of a large number of folks studied. And both of those infections had low tenofovir diphosphate concentrations consistent with low adherence. So moving into the adherence a little bit, there have been PK studies so that we can really look at how effective is PrEP if it's taken as prescribed. And so these sub-studies of some of the large clinical trials showed that the HIV risk reduction of efficacy if PrEP was taken as prescribed, so on a daily basis, 7 times a week, is 99%. And actually, even if it's down to 4 times, 96%. This is for men who have sex with men and for transgender women. Moving on to a recent study that was conducted in cisgender women, Dr. Marazzo presented at CROI this year a really interesting analysis. This was a pooled analysis, so 11 different demonstration projects in 6 countries to partly address, kind of taken as our mantra for a long time, that PrEP is less forgiving in women. And that's based on data from cervico-vaginal tissues, PK studies. But this study was really interesting in that it took on a new modeling study. So it used this group-based trajectory format to look at kind of, instead of just a snapshot of adherence, it looked at adherence over time. And so what the authors found when they analyzed women from these different demonstration projects is also that PrEP was very effective when taken consistently daily or consistently high. And where the large majority of infections were seen is when women had consistently low adherence or started out high but had declining adherence over time. So not overly, I guess, surprising, but just very interesting data that kind of gives us a little bit of reassurance about PrEP efficacy in women with slightly lower adherence. And with that, I will turn it over to Linda Gale.
Thanks, Meredith. And you've really set the scene. What you've heard is what we affectionately term our first generation of FTDF PrEP. Now I'm going to describe for you some modifications of that. And this really comes back to the value of choice. So giving people choices around their prevention methodologies. We know that when we turn to contraception, for instance, when we offer women a choice in contraception, we have better reproductive outcomes in terms of family planning. And we believe the same will apply to HIV prevention. So I think it's been terrific for the field that we've moved on to say what else is in the works for individuals seeking ARV-based prevention. And the first of these is what has already been alluded to, this concept of on-demand FTDF PrEP. Now, this was only studied amongst Frenchmen in Canada and in France. To begin with, the ANRS IPERGAY study was the first to explore this. And it describes the 2-1-1 regimen, whereby 2 FTDF pills are taken 2 to 24 hours before sex, another pill 24 hours after the first 2 pills, and then a second pill after sex 48 hours later. So this is on demand. It does mean that the individual needs to be able to forecast their sex ahead of the event. And you can see in this trial called IPEGAY that there really was very good protection, even in this scenario. And when they moved into the open label extension, where men could actually choose whether they wanted daily or the 2-1-1, there was really very good protection. We've gone on to see real world extensions of this. And here again, the NRS group showing very nicely in Prevenir that this holds up, that using FTDF in the 2-1-1 is very effective. And again, a second study, single center, open label, again, very effective, very little failure in this regard. Now, it is important to recognize that this has only been studied in men who have sex with men. Here is another study, again, looking at on-demand now in West Africa, again, encouragingly showing that this did provide protection, adherence being key, again, very importantly, and we can unpack this more. The WHO has gone on to say that this can actually be recommended for all men. And so this is, I think, a new frontier that we think about how we message it, how we get it out there. But again, important to know, this is not yet studied in cisgender women or people who are exposed by the vaginal mucosa. Here is the next kind of iteration, if you like. A close cousin of FTDF is FTC tenofovir alafenamide. It is a prodrug of TDF, and the good news about TAF is it has better PK. So as a result, there are fewer side effects, particularly bone metabolism and renal side effects. And so this is an agent we really want to know about for people who may have issues around bone density or have renal issues. And so this has been shown again as an oral regimen, daily oral regimen. The first study, known as Discover, was in men who have sex with men and transgender women, and you see a very favorable outcome, non-inferior to FTDF. Unfortunately, cisgender women were not studied, and so we don't have this indication for cisgender women yet. Here you see a comparison of when would you use FTDF versus FTAF for PrEP, and you can see very comparable effectiveness. Where it becomes interesting is when you move into these situations where renal function may be compromised or we have bone mineral density issues. A downside of TAF is that there may be weight gain, and this is why we really may want to think about baseline weight when considering either of these two options. Again, not studied in cisgender women nor in people who inject drugs. So for both of those populations, heterosexual women and people who use and inject drugs, we don't have any data. Perhaps the biggest movement in terms of what next has been this notion of injectable PrEP. And this is using an interesting agent. It's a strand transfer integrase inhibitor known as cabotegravir, cousin of dolutegravir. Cabotegravir is long-acting. It has a very long half-life. And in its long-acting form, injectable form, it only needs to be administered every 8 weeks. Really very exciting studies known as HPTN 083 in men who have sex with men and transgender women, and 084 for women who have sex with men, conducted here in Africa. We saw some of the best results we've ever seen. So you see an incredible 98% reduction in women, 73% reduction in men. Really very exciting agent. And of course, this takes out this need for a daily intervention. It's an injectable agent injected into the upper part of the butt muscle and coming to us all hopefully soon, and very exciting indeed. So with that, I'll wrap up where we are in terms of PrEP. You've heard in great detail how exciting our daily and 2-1-1 regimens are with FTDF. We've now moved into new agents such as FTAF and long-acting cabotegravir. And as I say, we can now also think about different dosing strategies depending on different populations. The take-homes are, don't forget to take a good sexual history. You need to know your client, what their lifestyle is, what their preferences are before deciding whether they need PrEP, and indeed together with them, and indeed which PrEP modality would suit them better. Choice is, we believe, a very important component of this. We think it will expand coverage and will enhance both adherence and persistence. On-demand PrEP, or the 2-1-1 regimen, is available for our first generation FTC TDF, not yet for FTAF, but it may be a good choice despite some limitations. And then, of course, the newest kid on the block, long-acting cabotegravir, is an option for most populations and has the potential to overcome barriers to adherence with oral PrEP. There are some drug-drug interactions. There are some gaps in our knowledge with long-acting cab. We can expand further during Q&A, but I do think this is a very exciting time for PrEP, and one that we're delighted you are so keen to hear more about, because I think it will revolutionize how we approach prevention in HIV. And with that, I'll hand back to Jessica.
All right. Thank you very much to our faculty for that excellent didactic introduction. So the first question from Salim asks about cross-resistance with NRTIs. And I am going to take this to mean if a patient does become infected with HIV while taking PrEP, is there concern for what they then can take for antiretroviral therapy if they've developed resistance to the NRTIs they've used for PrEP?
The most common mutation we would see is the M184V, which is the emtricitabine and lamivudine resistance mutation. And that we do see that develop in some cases. And so I guess, yes, the answer is that we would see cross resistance. And so, or we would see resistance. And so I think it just makes us cautious. And this we can talk about more, the need for RNA testing, and when we decide to initiate folks on PrEP, and in what cases we think that's really important that we would do that. But I think this just highlights that with INSTIs or with even daily oral TDF FTC and TAF FTC, that we really need to take a cautious approach to ruling out acute HIV, and then monitor patients while they continue on PrEP to make sure that they have not acquired HIV while on PrEP.
Yeah, so that's terrific, Meredith. I think the important thing to recognize is the most dangerous time is starting somebody on PrEP when they are seroconverting, so during that acute infection phase. Thereafter, if they're taking the PrEP well, they're unlikely to get infected. And if they're not taking the PrEP, they may get infected, but there won't be exposure to drug. Now, that paradigm may change somewhat with Cabolet, of course, but in terms of FTDF, that is an important concept. So very important that now in my setting, we're actually not doing antigen testing. We simply can't afford that within our PrEP setup. So it becomes very important for the clinician to ask those questions. When last were you possibly exposed to HIV? What has been your practice in the last little while? And if you have any concern that they may be seroconverting or that they may have been recently exposed and they're in the window period, you can, of course, start PEP. So post-exposure prophylaxis can come in with triple drug, and you can bring that individual back and then transfer them into PrEP very nicely. So there are guidelines for PEP to PrEP, which can just cover you for that individual. The alternative is to say to somebody, look, you're negative today. I want to be sure. Cover yourself with condoms. Come back in a couple of weeks' time and repeat the test. So these are some of the strategies we use where we're still very dependent on maybe third or fourth generation antibody testing in order to initiate.
Yes, absolutely. But I just want to add that in some cases it can be challenging, right? Because if you don't start PrEP that day and then they continue to have ongoing risk behaviors, you're putting them in a situation where you're not providing PrEP. It can be challenging for providers to kind of have these conversations, but just highlighting the need to really talk through when were your recent exposures. And really, if you are concerned, to emphasize, like, the last thing I want you to do is, if you're negative now, to become infected while I'm waiting. So please be very cautious, in that time where I'm waiting to bring you back to initiate PrEP.
Yeah. And PEP is your friend, right? Absolutely.
Yes, absolutely.
All right. Alicia asks, I tell male patients that the time to protection for FTC-TDF is 7 days and 21 for cisgender females. Is it a different time to protection for FTC-TAF?
Well, I'm going to jump in here quickly, Jessica, just to respond to Alicia to say we have moved away from the 21 days waiting for protection. That was the initial CDC guidance. I really think this has now been reworked for women who are people who are exposed by a vaginal mucosa. There is some concern that there needs to be more caution with that exposure because it takes a little bit longer to build sufficient concentration in that tissue, but it does not have to be 21 days. We are now talking about 7 days for women, both at the time that they are, before they can be exposed sexually without condoms if necessary. And then there needs to be a 7-day period if they stop PrEP where they may still, where we want to think of other methodologies before they lose the protection of the PrEP. So it's important that we talk about the reduction. Now, when it comes to women, we don't have any data for FTAF. So it's kind of moot in terms of FTAF. I'll hand back to you, Meredith, around for men.
Yeah, and I do say 7 days. We don't have the data. We actually think that in immune cells, the TAF FTC achieves the PK, the concentrations even sooner. So I think 7 days is just a good, since we don't have, exact knowledge, that's a good, just kind of across the board, 7 days for men who have sex with men and transgender women. Yeah, if anything, maybe a little sooner, but we don't really for sure know.
And I would take heart from the fact that we've got good data on 211, right? So 211 would suggest, certainly for FTDF, that 2 doses, 2 to 24 hours before sex, and then the second dose and the second dose is protective. So I think we can draw some reassurance in the setting of men who have sex with men where there's anal rectal exposure. This is a safe way to go.
I think some providers are not even talking about the 7 days at all anymore and just telling men who have sex with men and transgender women to take those 2 doses up front prior to sex and to kind of achieve those PK levels more quickly. I think it's sort of provider dependent at this point, and it also depends on what the patient wants to do. And, sometimes I have folks coming in saying, I took TDF FTC before, but I had a lot of GI side effects up front. So maybe you don't want to tell them to take 2 the very first day. So I think it's a little dependent upon the situation.
Agreed.
And both Alicia and Derek ask, is there any evidence for on-demand use of FTC-TAF?
So I think that those studies are underway. We're waiting for confirmatory data, but it's not yet in our guidance. It's not yet available to us. The on-demand regimen at this moment remains only FTDF.
Okay, and then going along with on-demand, Maria asks, what is the recommendation for men who have sex with women in regards to PrEP on demand?
So maybe I'll pick that one up because we're kind of promulgating it here in Africa. WHO has, for reasons of simplification, I think, have come out and said all men can be recommended for the 211 regimen. Now, one of the things that applies here in Africa is that there's a lot more emphasis on providing PrEP for women who have sex with men, particularly younger women. And then young MSM would be our other key population, simply because, there are large numbers and a lot of demand and not a lot of access to PrEP yet, for reasons of cost and affordability and so on. So, the emphasis has not been on cisgendered men to date. But I think it's interesting that WHO has come out to include them in the recommendation. And, maybe this is a good time, Meredith, just to say that WHO is working really hard to try and bring this concept of differentiated prevention delivery. So really trying to demedicalize PrEP and make it as easy for people to access and use as possible. So I think this is part of the effort to say, let's meet people where they are. hence the importance to understand their sexual lives, their sexual preferences, because we really want to make this as unmedical as possible, whilst obviously still being safe. We want to get to people where they are.
Yeah, and I think that conversation, at least in the U.S., has been going on for a long time. What can we do to demedicalize PrEP and make it easier so that, here we're trying to encourage GYN providers to prescribe PrEP and primary care providers to prescribe PrEP. It is, with all these additional options and new guidelines and different testing strategies, part of it is growing increasingly complex. But what I try to say to providers often is you're prescribing these medications that are complicated for contraception and hypertension and diabetes. I think providers sometimes hear, oh, this is a antiretroviral drug, and they get scared. But if you really say, this is actually very simple. Here's a chart. This is all you have to do. This is all the counseling that you need. I think we will get there eventually, but it's taking some championing on the part of some of the, I think, ID folks and the people who really firmly believe in PrEP and advocate for it.
Robert asks, Dr. Linda, in settings where both are available as the superiority of long-acting over oral in 083 and 084, would it be ethical to first prescribe oral PrEP instead of injectable?
Yeah, it's a great question. And, interestingly, with the vaginal ring, maybe I'll go there quickly to just describe. So with the vaginal ring, we had a slightly lower efficacy in the clinical trials. So about a 31% efficacy in the clinical trials with DAPI ring, as we refer to it, DVR. And so when the EMA made their recommendation, which now has been promulgated in a number of countries in Africa, the label says that the Piperine ring should be offered as a second choice if oral PrEP is not available. Now, ironically, when we did the oral PrEP randomized controlled trials in Africa the first time around, we actually saw no efficacy. Subsequently, as Meredith beautifully described, when it went into effectiveness demonstration projects, that's been shown to be very different. And you saw the beautiful data that Jeannie Marazzo showed at CROI, that really we should feel reassured that oral PrEP is a very real prevention option for women who have sex with men. Now, enter Cabolet, and we see an 89% reduction in incidence that really, compared to oral PrEP, that really, makes you sit up and smell the roses, if you like. But the important thing to recognize is there will be individuals who don't like needles, who don't want a large injection in their butt every 2 months. This will not be a good option for them. And we know that when somebody's doing something not because they're perceived to be ill or sick or in need of it, they will easily move away from it if it isn't something they have to do. So we think offering people injectables if they want it and oral PrEP if they want it is the way to go. But you're right. There is an element of counseling where you sit with an individual and you say, how easy is it for you to do a daily thing? And if they say, I forget just about every other day to take my X or to turn up or I'm a very forgetful person. You might in that setting say to them, well, do you think an injectable that you can have it in and forget about it isn't going to be a better option for you? So I think there's going to be, hence the need to sit with your client and really get some rapport around what they want. So I think it's less about ethics and far more about ensuring that we provide all of these modalities work. We really want to provide the right modality for that individual because we think that's more likely to be used. Meredith, I don't know what your feeling is in your population.
Yeah, well, I just want to add, I kind of extrapolate from my population, from my HIV care treatment population, where, sometimes I have patients who come to every single visit, but don't take their medications. And then on the other hand, I have folks who never come to their visits and take their medication every day so that when they do come, their viral load's already suppressed. And so I think I totally agree with you. It's about having that conversation, the counseling that goes into it. What option is the best fit for your lifestyle? And if you think you can come to clinic every 2 months, but forget pills, then maybe we go with CAB or vice versa. So it's about the fit and providing options.
Thank you. Derek asks, how long is the half-life for long-acting cabotegravir? And what should you start if someone becomes HIV infected while on long-acting cabotegravir?
Yes. So I'll just say the PK data for cabotegravir is very complex and a little dependent on assigned female or male at birth, BMI. We look at the peaks and the troughs. I believe from 077, we did see that cabotegravir could remain at detectable levels for upwards of 70 weeks. And so it can have a very prolonged duration of detection. So we do have to be cautious. I think what's reassuring now that we have more and more data from 083, is that all this concern about the PK tail phase and covering the tail seems to be a little less of a concern. Now we have, I believe, 16 cases of folks who were infected without recent cabotegravir exposure and no cases of INSTI resistance. And so not to say that those folks who have been on CAB and gotten injections can't become infected. But I think we're a little more reassured now that those infections are less likely to lead to INSTI resistance, right? So in the setting of an infection that does occur, particularly in somebody who's getting on-time injections or somebody who is becoming infected, like Linda Gale was talking about earlier, like they had acute infection and it was missed and then later picked up so that they started CAB-LA during that period. I think we would be much more concerned for INSTI resistance, and that would be a time that I would strongly recommend a PI-based regimen for those when you ultimately do detect HIV, but you are concerned that it was perhaps a delayed diagnosis. Do you have other things to add to that, Linda Gale?
No, I think that is absolutely right, Meredith. I mean, the concern obviously with CAB-LA is it's monotherapy. So we don't want people to be exposed for a long period of time on monotherapy. And there was a huge amount of worry about the tail. Now it's actually turned to the initiation. It's important to say the FDA has come out on their label to say that there should be antigen NAT testing in order to initiate. That hasn't come through in the WHO, and it's unlikely to be a recommendation. Certainly our label in South Africa does not require that because it would be an enormous barrier to CAB-LA use. But, again, cannot emphasize enough, we must be cautious about who we initiate. And where possible, we should at least use a third or fourth generation, possibly, test that shortens the window. And just helps us pick up acute infections. The problem with the acute infection been labeled a thing called a Levi syndrome. All that really is about is that you can mask somebody has actually been infected with HIV and has underlying HIV infection for long periods of time. And that's come through in 083 particularly, although we now have a couple of cases in 084 as well. So I think this is a space to watch and see what happens. But again, the modeling studies show without doubt that the numbers of cases we will avert through the use of CAB-LA far outweighs any worry about breakthrough infection and resistance. So again, I don't think this is a reason not to go down this road. And we're very excited about CAB-LA.
I think this goes back to demedicalizing too. We can spend all this time talking about these very few cases and how to address them and how to think about them very cautiously. But really, we should be so reassured that it's such an effective kind of game-changing PrEP agent.
Correct.
Preston asks a question related to you, Linda Gale. How will the uptake of CAB-LA for PrEP change treatment guidelines? For example, the use of TLD in South Africa.
So these are old conversations that the infectious disease world has around don't use treatment drugs for prevention because we worry about prophylaxis. We always worry that prophylaxis might undermine treatment. And rightly so. Nevertheless, we're down to a few options around antiretrovirals for prevention. And there's no doubt that cabotegravir long-acting is very important for prevention. In the same breath, we've just rolled out to millions and millions of people this wonderful single dose, single agent combination drug of TLD. And it's very important that we continue to do that. We think it's going to revolutionize treatment as well. The good news about the integrase inhibitors are that they have a very high bar for resistance. Unlike the non-nukes where, we had that problem where resistance occurred relatively easily and we would never use non-nukes as a prophylactic agent. We do have the very safe drug, very easy class of drugs to use, and a good high-level bar to have to cross in terms of resistance. So I don't think it's going to modify our treatment at all. We obviously need to have some surveillance going on at the same time to monitor what's happening in terms of integrase inhibitor resistance. But to date, it's looking great. And I think we need to go forward, knowing what we know today and monitor, but move forward nevertheless. So I don't see it changing our guidance, in the short term at all.
Great. Alicia asks, are there pregnancy concerns with CAB-LA? Should our patients be on birth control if we are considering prescribing it?
Meredith, I don't know if you want me to pick this one up. I spend a lot of time worrying about this. So women of reproductive potential often get left behind, right? And unfortunately, as often is the case, although I think this is changing, you will be hearing that there is an interesting other agent that is a 6-monthly agent. Those trials are currently in the field. And the good news is women are allowed to get pregnant on those trials. So I think we are shifting our paradigm in this regard. But the initial 084 study, women were put on contraception and needed to say that they would contracept through the study. And then, of course, we had the Botswanan data to show that, or the signal that suggested that dolutegravir in women who live with HIV may have caused a congenital abnormality in their unborn children, particularly a neural tube defect. This has been shown to not be a real signal. This was an early call. It was down the line of stats, but that put a real brake on 084, which was unfolding as a clinical trial at that time. We had to really redouble our efforts around contraception. The good news is that story has been rewritten. We now know that dolutegravir is safe in pregnancy, and so we are able to go forward in this regard. And so now the open label phase of 084 has loosened up on contraception, and we have had an explosion of pregnancies in 084 open label, as is often the case in Africa. It's very delightful that many of the women who've been in trial now for a number of months are now able to exercise their right to fertility, and they are pregnant, and we're following up those pregnancies very carefully. We've had a number of the pregnancies come to term. We really aren't seeing a signal at all. But at this point, the label in South Africa does not say no to pregnancy, but, there's almost certainly going to be a little bit of guidance around that until we really see the 084 data coming through. There are some studies specifically looking at pregnant women, pre-conception, as well as during pregnancy starting CAB-LA. So I think that data is going to come soon, and I'm hopeful that it's going to be positive, but it isn't quite out yet. And you'll know that the FDA has not allowed pregnancy and CAB-LA. The FDA label came out a little bit sooner than ours have in Africa. So I think this is an evolving story, and I hope we'll soon have better data. Meredith alluded to the fact that PK may look different in pregnant women, so I think that's important for us to note. And so, we also want to be sure that our dosing strategies are good in pregnant women, etc.
All right. Musa asks, what would be the optimal PrEP regimen for a discordant couple where the positive partner is on PI-based regimen?
I would think that unless there were concerns that the primary partner had resistance, either NRTI or NC resistance, then either option could be used. But Linda Gale, perhaps you want to expand upon that answer.
I want to say, my first question will be, is the person living with HIV adherent on treatment and virally suppressed? So if they're virally suppressed, I don't really care which ARV they're on. because we know that U equals U, right? So if they're undetectable, they're untransmittable, they're not going to pass their virus on. So it doesn't really matter what it looks like. If there is concern, and Meredith, I fully agree though, if there is concern that there may be adherence issues or they're not virally suppressed, we're talking about, second or third line, and maybe they're struggling to get suppression, then a drug history is going to be really, really important. And of course, de novo resistance is one of the reasons you may see breakthrough infection for prophylaxis. And so I really would want to know the drug history of that individual. And if you could get your hands on a genotype, that would be helpful. But I think that's a complex case, and I wouldn't expect somebody to take that on without getting some help from an HIV specialist or an HIV expert to just help you through that one. As I say, it really becomes moot if the partner is undetectable. You could argue that maybe even the partner doesn't need PrEP, but we do know that in discordant relationships, sometimes if it's a new partner and they're not entirely au fait, the negative partner may want to think about PrEP for a time. And, then you could have a discussion around whether the PrEP was warranted in a continuing space. So again, couples counseling would be really, really valuable under those circumstances, to sit both parties down and have a good conversation, and have a viral load on hand to make a decision.
And just to reemphasize the importance of those U equals U conversations, that's the most important here. But I talked about, you have these conversations with your clients about having happy, healthy sex lives. And for those who do have HIV, hearing U equals U, undetectable equals untransmittable, you're not going to give HIV to your sexual partner, I think is so empowering. It makes a world of difference to those folks.
It's a great cousin to PrEP. So when we put PrEP and U equals U together, we really have a chance to bring HIV under control. It's very exciting.
Right. Roberto asks, in your clinical practice, do you perform STI testing at each visit? And do you suggest, if available, any point of care testing?
I'll hand off to you first, Meredith.
Yes. So it depends on availability and in some cases insurance. For men who have sex with men and transgender women, which is a large part of the population I see, the guidelines would be every 3 to 6 months. And you sort of tailor this around, again, the importance of sexual history taking and what your clients are telling you about recent sexual activity. But yeah, we do syphilis, gonorrhea, and chlamydia testing quarterly for most folks. And as far as the point of care test, it depends what you have available. So we do the rapid syphilis health check. That's a treponema test. And so for anyone who has a history of syphilis, we would also send out an RPR. But for those clients who don't have a history of syphilis, we can do that point of care. We are in the process of our STI clinic. We're engaged in a number of diagnostic studies to validate point of care tests. So I think more and more those are going to become more heavily used. Also, there are a number of kind of at-home tests, mail-in kits that are being validated and are really exciting to some clients who don't want to come in or, might have, I guess, just discomfort with the whole process of talking to a provider and doing testing in a clinical setting as opposed to the comfort of their own home. So yeah, all those tests are kind of down the line coming, and I think are going to be used more and more for patients on PrEP, for people with HIV, and for people who want routine STI care.
And I'll just add that here in Africa, often our standard of care is actually syndromic management, which is really non-ideal. In my own practice, where we provide more than the standard of care on my mobiles, we do use point of care. And the syndromic, obviously, you can ask at every visit whether people have symptoms and treat appropriately. For where you're able to do an etiological diagnosis, I agree with Meredith. Quarterly is wonderful, but I would say at least 6 monthly if the individual is very sexually active, and at least annually. And then don't forget also notification or getting treatment to partners, because there's a lot of reinfection that's going on.
I think we could slide in the question on implantable PrEP quickly. Yeah, go ahead. I'm sorry if I'm jumping ahead. But I did just want to say islatravir was going to be used as the implant. Many of you are probably familiar with the data on lymphocytopenia and specifically declines in CD4 cells with the use of islatravir. So, it's only going forward in certain situations with the lower dose. They do have another compound that they will be developing. So it's pushed back the timeline a bit, but I think there's still promise that we will see one in the not so distant future.
Yeah, and just to add to that, Meredith, I know there's a Cabernet version that's being looked at by, various developers and a TAF version that's being looked at. So hopefully we'll see an implant which may be 6 or even 12 monthly, but also look out for the injectable that's coming. That's going to be 6 monthly. So there's lots of excitement in the PrEP pipeline.
And I was going to add to, I don't know if we said this specifically, Linda Gale. So we are a Purpose 2 site for lenacapavir for men who have sex with men and transgender women. But Purpose 1 is in cisgender women in sub-Saharan Africa. There is an arm of that study for TAF, if I'm not mistaken. So we should have more data on TAF and cisgender women also in the not so distant future.
That's right. So lenacapavir being tested with a endpoint of comparison to background incidence, and to FTAF on a daily regimen. So yes, we look forward to seeing that data.
Thank you very much to Dr. Becker and Dr. Clement. And thank you to our listeners for joining in. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.